fashionably late. Those who have noticed I've taken off my tie. It's not out of deference to any of you, it's because I had to protect myself against the udon spray from the absolutely superb, by the way, noodle soup. Apologies, the Korean rice guy will be here next time. All right, so I thought we had a really stimulating morning. I feel full of energy, hope you do. And we have some really interesting issues to tackle this afternoon. And first up is David Myers, who's Chief Medical Officer, and we're going to talk about opioids.
Absolutely. Thank you all so much. About a year ago, the NAC invited me and we had a discussion about what AHRQ's role could be in the opioids epidemic. And so Jamie said, you know, you should update the NAC on what we're doing. And that was the original plan for this, but I think we need to really change that given the tone of this morning's conversation. And instead ask you all to think about, I'll give you the update, but I'd like you to think with us about what else could we be doing? Where are the opportunities that we might not have yet identified that you see out there outside of the Beltway for AHRQ in our three areas? And if I had had more time, I would have redone the presentation to help you see it in terms of health services research, practice improvement, data and analytics. That's how AHRQ works. So with those three fundamental capabilities, where are the other roles for AHRQ? But with that, so what are we doing? We are part of the Department of Health and Human Services, and all hands on deck to support the department in supporting the nation. And HHS has a 5-point strategy. It is not based on a logic model, it's based on a practical model of where were the gaps, what was needed, what would make a difference now. And our current secretary actually is holding the department to seeing results in the opioid crisis in America turn around over the next 3 years. And his priorities are laid out in these 5 pillars: better addiction prevention, treatment and recovery services, so treatment for people suffering from opioid addiction, having better data to let us track and understand the epidemic, better pain management, which I would say is also part of, in general, prevention, helping people not even start on the path towards opioid addiction, increasing the use and the availability of overdose reversing drugs to decrease deaths from overdose. And I was fascinated and thrilled that the department also recognized a need that just doing what we do now won't be enough. We have to answer some of the unanswered questions, so better research. And so AHRQ is part of all 5 of these. I won't go over in detail the next few slides, but what they are showing you what we've already done in these areas and what we're currently doing. And I recommend them to you if you want to learn more about this. They are all linked, so you can actually go and trace this. I think it was Tina who challenged us to make this all available. If you go to ahrq.gov/opioids, we do have what is called a information page. It pulls all of our stuff and puts it in one place. We are not satisfied with this. I accept your challenge. When you meet again, let us know if you like what we've done. We are actively working on a plan to tell that story of AHRQ's role and what we're doing and make these resources more available. In the area of prevention, treatment, and recovery, we already have collected tools and made them available in a curated way with our traditional focus on the primary care practice. We have a technical brief that also summarized the evidence about medication-assisted treatment and how it's working and how it's not working, and what are things states, healthcare systems, and primary care practices can do to move that forward. We talked about this in our March meeting. Our team at the Division for Health Information Technology has really done exceptional work in trying to create a uniform standard for electronic clinical decision support, something that will empower many, many other things. But their use case this year is in opioids and taking the CDC's guidelines and others, both in pain management, we hope, and MAT, safe opioid prescribing, and making them into reusable artifacts that anyone who works with electronic health systems can put forward. Other things listed there. I'm going to take you on a slightly deeper dive in what we've done with data and analytics. We have used both HCUP and MEPS. And as Mr. Khanna has really challenged us, thought about how do we make this data actionable for policymakers, and that's what I'm going to show you. And we'll be continuing later this summer, early fall. We should have a series of new data briefs focusing on opioids and older adults. something that I think is a sleeping giant right now in this problem. We're focused understandably on overdose deaths and fentanyl and heroin, but as I think I have some of the data, the rise in people over the age of 65 being seen in ERs and hospitalized for opioid-related problems. They're not overdosing. Their memory problems are getting worse. They're falling. Their blood pressure is getting out of control. And it turns out this probably has something to do with multiple chronic diseases and polypharmacy and chronic pain, creating a stew that if we don't get a handle on, is going to get worse moving forward. But here's some of the data. So here's a map of the United States showing change in the use of hospitals for treatment of opioid-related conditions. Look for the light green, which are the only states who didn't get worse. There are not many of them. And you look at the dark blue and the purple, there are many of them. You all knew this, but it's just pointing out this problem is our whole country's. But when you look more deeply, it's not the same problem in all locations. This map shows who's most likely by age to be hospitalized for an opioid-related condition. We have the same map for ERs. Looks relatively similar in that it's different in different places. It was used to be thought this was a young person's problem. If you look, you can see that in Illinois, it's, well, I don't want to offend anybody, 40 to 60-year-olds, also in New York, but in California and Texas, it's now the most likely person to be hospitalized in those states for an opioid-related reason is somebody over the age of 65. And all of that light blue is what I was mentioning earlier. This was HCUP 2016. And just as a test your knowledge, it's a trick question. Are men or women more likely to be hospitalized due to opioids? Anybody says men? Come. Okay, we'll see. Anybody say women? Who doesn't want to bet? Okay, I'll show you. But it's good to think through before we test our assumptions. It's women, and it's women almost everywhere in the country now. This wasn't true 10 years ago. Women have achieved parity. Not a good thing, but moving forward, it's just a reminder that our assumptions need to be challenged and data helps us do that. But how do we help states do that? This is an example where we drive down the data to the county level. We can do this in more than 35 states, showing the rate of opioid hospitalizations by county. And in the same way the country doesn't show the same map, individual states don't show the map the same way. Moving forward, is a reminder that AHRQ data has shown that while opioids are where a lot, and appropriately our attention is, in every county in the United States, alcohol is the #1 substance likely to lead to an admission, not opioids. That problem hasn't gone away, and in some places, this is Arkansas, it's significantly more likely. But then we can drive it down even further. Oh, sorry. So there's we showed the data, this same sort of data at the county level. You saw the Arkansas map earlier, so I stayed with Arkansas. These are where 2 of the larger cities are in Arkansas. And while alcohol is #1 in both counties, you can see the difference. Oops, I'll get some of these to show up. Opioids is #2 in the the northwestern part of the states, but it's actually cannabis coming in at #3. And #2 is actually inhalants. People sniffing. And so what that county needs to do may be very different in how they prioritize it than the other counties. So that's how AHRQ is taking our data and trying to make it more available and more useful for local policymakers. Pain management, as I said earlier, is part of can be part of our prevention of the opioids epidemic. We recently completed a systematic evidence review on non-invasive, non-pharmacologic treatment of chronic pain. Folks in the field have been needing this. What works to control pain before you reach for opioids? And I'm really excited to say that our colleagues at CMS have expressed great interest. They followed along with this report and are already trying to think about what levers they have to make sure that payment follows the evidence in this field. Second project is dealing with teaching. This was originally for small rural primary care practices. We're expanding that in a testing way right now, but helping practices understand the continuum of chronic pain management safe opioid prescribing, and their role in either initiating or actually providing MAT, and that's called the 6 Building Blocks Project. So more on that hopefully next year. In research, we haven't had much budget available, but we've used our investigator-initiated research funding, and people have been bringing grants to us. Last year, over $2 million funding about 6 to 8 projects, specifically in this area. And we have a specific targeted Congress, or actually the department asked us what we could do in primary care. And so we are working with Oklahoma, North Carolina, Colorado, and Pennsylvania to explore how primary care in rural areas can be part of the solution for making medication-assisted treatment available. Many people need the service. Many of them, over half, probably don't have access to it. In urban centers where there are community-based substance abuse treatment centers, that may be the locus of expansion. In rural areas, it's unlikely if primary care doesn't get to be part of the solution that will ever receive it. These folks are looking at why, and naturally why, primary care doesn't do this, and what can be done to empower them to take this on. It's about 2 out of 3 years into that funding, and so we're looking forward to those findings. That leads us to my final question for you, though. So in that research space, where do you see the greatest gaps? Where do you see the greatest opportunities? What will we need to, and this is how I think Jose answering some of the questions that we heard earlier, we like to try to think about in these big fundamental research questions, not what are people struggling with today that they need answers for today, but what will they need in the future? And how can we get the research community to start those projects now so when the nation needs those answers, we have information to give them. We also recognize, and as you all started with earlier, what new ways of research funding, what new kinds of methods, what kinds of partnerships should we be exploring in this field? It might be the same as what you tell us for all of the HSR agenda, which we'll talk about in a minute, but this area might have something special. So if you have ideas, please share it. And we also always struggle with however much funding we have now and in the future, it will be limited. And the balance between pure research and hypothesized generalizing research and dissemination and implementation work. Where do we go? So again, thank you, Lucy. And Don, you tell us how much time we have. And we'll take as much.
Well, technically we have 15 minutes, but I don't know.
Well, it's okay. Let's just see where we go. We'll keep the dialogue going.
We will budget. Can you clarify one thing before we take the questions? I'm probably not up to date on this, but I thought that dissemination monies had been cut. Do you still have funding for dissemination activities?
We do.
Okay.
The president proposed, and for those of you who were at our orientation yesterday, this is a complex process, but the president in the presidential budget proposed eliminating AHRQ's dissemination contract work. Congress did not in 2017 or 18 accept that recommendation, so AHRQ still does have funding. And at the moment and through 2019, we also have funding from the Peace Corps Trust Fund to disseminate and implement evidence.
Okay, that's good.
So we're
That was
still
one
in
of your
that.
questions.
Yep.
I want to make sure there was money for it. Okay, so why don't we start in the other direction? All right, so Lucy, I guess you're up first.
There's also
Well,
in the
I
corner.
think Sheila, if you're starting in that direction. Sheila
in
has
the
her
corner.
card up.
Oh, it's at such an angle I couldn't see it. I'm sorry.
No, so hard to see. Sheila Burke, I just had a question in terms of new opportunities and partnerships. To what extent, in looking at the issue of pain management, have you begun to look at training? And that is the extent to which we're either talking to the AAMC or to the AACN. What are we looking at, not only in terms of training and knowledge operations for practicing physicians and nurse practitioners and others, but to what extent are we taking a step back for the new generation to begin to think about how we rethink pain management as part of their training experience?
I'm going to answer your question, but first I'll ask you. I'll answer, but first I want to ask you, do you think that's a high priority? Should we be in that space? Should someone be in that
Well,
space?
if you think of the retirement of a certain generation of physicians and nurses that's occurring, it would seem to me that those that are in their residency programs that are, one, we're incentivizing them to go into primary care in a variety of ways, not the least of which is the core and the commitment to the core. I think there is certainly a partnership there to occur about what you know and how you can inform the Council of Teaching Hospitals or others about how they think about what their, training programs look like. It's not clear to me that you will need to do a great deal in terms of new information or new research, but rather what are we gaining from the research, and is that an audience that we ought to think about?
So perfect. AHRQ, I think, has an important role in packaging what's already known and making it available to health systems. And you're saying to us, should we think about packaging and making that available to the people in charge of education? In general, I think AHRQ within the HHS family defers to our colleagues at HRSA, who have that specific mission, to our colleagues at VA, who have that mission, and a little bit at CMS because of their payment for graduate medical education. But HRSA is generally the departmental lead in both nursing, PA, pharmacy, and physician education. That said, it's a big space and everybody needs help, so it's one we should continue to think about. AHRQ tends to take the role of trying to help with educating those already in practice, which is part of quality improvement, practice improvement, safety. So we're always already there, and it might not be hard for us to try to pull that back.
And my only addition is that, in fact, particularly those that are in their residencies and those that are in PhD or master's level practice training programs are in fact training and in fact practicing. So it's not a big disconnect between people that are fully in practice and those that are in the last stages of practice.
Absolutely, great
so
point.
I would look at that as an opportunity of the new generation coming in.
Yeah, one of the most exciting programs I've seen is training all of their residents to get them the MAT certification. So no matter where they practice, they already have that as residents. So
let's go in order if that's okay. So Lucy, then.
Okay, 2 points quickly. So one of the things that I have been sort of harping on for the last couple of years is dentistry. I think it's like the soft underbelly of this problem, mostly from my own personal experience. After I hit 60, I've been in the dentist office like every other month. But I will tell you, at Intermountain, I had a dental procedure done in December before I left, and they would not let me leave without a bottle of 50 hydrocodone. And I'm like, I drink wine, I'll be fine. And then I just recently had a dental procedure now under the Kaiser system, and Kaiser Northwest is the only Kaiser region that has integrated medical dental. And they were trying to make me leave with 30 hydrocodone. And again, I pointed out we have even better wine here. So, and there was that article that came out, I think in 2016 in JAMA, New England Journal, where they showed for the Medicaid population that there was an overprescription of these drugs for dental procedures. So I think primary care is an important place to look, especially if you're looking at osteoarthritis or other kinds of things. But dentistry, I think, is a piece that we're missing because it's sort of the gateway for a lot of these things. And then the other area that I wanted to comment on, and it's really sort of in some ways segueing off of what you said, is I think we need to help people rethink the culture of pain and what does pain mean. There's a great book by Lemke, Drug Dealer MD, and I had her come speak at Intermountain when I was there. And the culture of how we think about pain in the healing process really changed with the advent of these drugs becoming available. I have a good friend who's an orthopedic surgeon, and he had practiced at Dartmouth, and for 10 years he's been in Sweden. And I was talking to him, and he said in the 10 years, and he does like knee replacement surgery. In the 10 years he's been there, he's never prescribed anything other than like a Tylenol or an ibuprofen for pain management. And so our country, I think, thinks about pain management very differently than others. And one opportunity that is well understudied is, now that we have so many states that have medical marijuana at least, what about CBD and use of CBD in practice, and what do we know about it? There is very limited evidence around that.
great suggestions. Thank you, Lucy.
Yeah. If I just follow up on that, to what extent is AHRQ able to, or does it try and learn from evidence in other countries?
We're a small agency, but we try to learn from everywhere we can. Our evidence review system, our evidence-based practice center program, is famous for looking at evidence both in the US and outside of the US and trying to incorporate that. So we always do that with them. AHRQ recently held a conference, what can the US learn about primary care from Canada and what can Canada learn from the US? So we're trying to do that. The environment in DC sometimes is more supportive than others in doing that, but we believe knowledge should cross borders.
And I have Karen, Will, Barbara, Tina, and Christina. So Karen.
Thanks. This is Karen Amstutz. I wanted to chime in on the first question you had, which is suggestions for the role of HSR in combating the opioid crisis. And one of the areas, and this really plays on other comments earlier today, that needs additional study, particularly in the area of medication-assisted therapy, is not the actual efficacy of the medications, but exactly what needs to be provided in terms of psychosocial supports and care coordination. So what exactly are the tasks and the services, and getting an evidence basis around that.
Excellent.
Yeah, well, I'll build on that. Those are incredibly helpful comments. I think for those of us that come from systems or sort of involved in treating or managing these folks, so at my organization, we spend more money managing patients with opiate problems than your budget each year. And we're doing we have an incredibly rich, robust portfolio of services that we're trying to deliver. We are doing our best to evaluate them as fast as we can and to try to learn which is the right sort of constellation, how they add up to each other, what is the right sort of amount, what are the right kind of services to wrap around a member and their caregivers and their family. What information do we have about their family members and their use of opiates? But we're throwing good money after bad at this problem. There's no way we're managing these patients as efficiently as we can, and we certainly are not managing these patients as well as we can. And it is absolutely not from a lack of effort. So I think one thing, I would encourage you to help synthesize what's out there and help sort of gather some comparative effectiveness research based on what's being done in the field, rather than prospectively start putting new interventions or tests out there, because there's enough being done out there right now that we can learn a lot. The second thing is, for us, one thing that's been incredibly helpful is when there are policies implemented that give us cover. So in the state of Pennsylvania, there was a policy implemented in Medicaid that said you can't prescribe more than 5 pills for a set of diagnoses. CMS has provided some additional cover with specific criteria about how much can be prescribed. That changed our ability, our leverage, our negotiating with our physicians around commercial insurance, because if we're doing it in Medicaid, we're going to do it in Medicare. To the extent that AHRQ can help sort of define the policy impact of the impact of some of these policies on prescribing, on health and costs, that seems like it's right in your wheelhouse. And to the extent that that could lead to more rapid dissemination of those policies, you could see a real fast sort of turnaround in terms of the impact of your research on how patients are getting their meds.
Excellent.
That reminds me to ask a question, David. In terms of synthesizing the resources, so NQF came out with its opioid playbook, and with a lot of stakeholders involved. And as you look at that, does that leave gaps that you see immediately that AHRQ can fill, or is it done in parallel? What's the level of collaboration and need that remains?
Thanks, Don. I think a series of different questions. The first thing I'll reassure you is we are partner with NQF. We knew about the playbook. We gave as much advice as we could in its development. We're excited. We're, one of the earlier slides, we're building a website to put all sorts of materials, not just AHRQ materials, in one place so people can find them. What we're seeing is that there is some duplication happening now. Everybody is in this space. And so we're reading it to try to say, where do we think there were still gaps? Where were there thin places? But I'll let you tell us where you think. But I promise you that's what we're looking at. Will, I can't say it publicly, but I am so with you on that natural policy experiments that are happening right now and the opportunity to learn from them so that we all do this better. We hear you.
Barbara, I think you're up next.
So thank you, Barbara Fain. So I think in terms of that last question, the balance between research and dissemination and implementation, it's a really good question. Obviously, if there's research that you are doing that only you are doing and only you can do, or analyses, that's incredibly important. As is the dissemination and implementation piece. And I think sometimes, this is a relatively new area of focus. It's a high priority area of focus, and sometimes that offers an opportunity to develop and test some new models for dissemination and implementation, some of which would potentially, or elements of which would be applicable throughout AHRQ, through all of the other amazing resources that you have here, because there is so much sort of sitting on the other side. I was, 4 years ago when I started in my current role, I was really stunned at just when I finally found my way into your site, just how much is there that I know is being underutilized. So, and one thing is also thinking about, it's an opportunity to think about target audiences and how you really develop a communications strategy that starts with who am I trying to communicate with, what am I trying to communicate, and what are the communication channels that are going to reach those different audiences. And so it's really a multifaceted approach, but I think this could be an opportunity to really dive into this in a way that not only helps spread the whatever the knowledge is on opioids, but could be applied throughout the agency.
Great point. And I can reassure you that we have an interagency work group, so drawing from all of our resources working together, and that includes 2 of our colleagues from the Office of Communications, including the one who understands social media, which I don't, and so is trying to push us, and we're encouraging him to try to push us in this field, but for exactly those reasons. And I love that kind of thinking, that if we can learn how to do things and build audiences because of their interest in opioids, but then show them our safety stuff, or then show them our other data resources, it's a win-win-win. So it's a great reminder to us. Thank you.
Tina, I have you next, and I've added Kathy, and then at the end, I think Shari and Chesley both have their cards up.
Okay, so I think it's important that we remember how we got here, right? We got here because we said we were under-treating pain. And so it's the pendulum. So now we're saying, we're stopping opioid prescribing. And so we have patients coming to our clinic all the time with chronic pain who say, I can't get my pain medications. And so I think AHRQ could have a key role in understanding what's the patient perspective here. What is the patient quality piece that we need to look at? How do we treat those patients who really need that pain medication, and versus the focusing on the prescribing and these policies that are coming out that really are not evidence-based. I mean, throwing a 5-day supply for all new opioid prescriptions, there's a lot of evidence that suggests that's not the appropriate way to prescribe for postoperative pain, for all of these other things. And so I think if you think about how can we start putting the patient into this research perspective, thinking about we got here because patients were being undertreated for pain, and also start thinking about what is the right way to prescribe these opioids instead of treating the average patient where we're saying a 5-day supply is great for everyone. Start thinking about what are some of the social determinants of health that need to go in this equation, what are some of the social factors, what are some of the previous exposures. How many opioid naive patients do we have now in the care setting? And all of our medication prescribing are based on opioid naive patients. So thinking about those different perspectives from the patient, I think, would be important.
Great reminders on the patient perspective and what we can bring to that. reminder to me that I didn't say, we are coordinating in this research space with our colleagues at PCORI, who've actually done, and we partnered with them on some really important studies to answer some big questions, which they could do, but also our colleagues at NIH and the HEAL program and what they're doing. And so one of the things we're trying to do and asking you is what's not being done with those others to make sure we're focused. So the patient perspective, I know there was a second part of that, and I hope my,
I think it's treating the average patient, right? And thinking about a personalized approach to treating pain.
and that was exactly it for me, is that we will never, I hope, at AHRQ, talk about the opioid crisis without pain management. These are linked issues, and if the pendulum, we'll start it all over again, so that appropriate pain management is the start of all of this. Thank you.
So just a question of follow-up for a second from previous comment. So when you're having these collaborative discussions, let's say with CMS or with PCORI or whatever, and something especially of a policy nature is brought up, we think we can be helpful by having a 5-pill policy or whatever. Do you then say, and we can help you determine the impact of that using health services research?
Yes.
Good.
I don't
like
always
short
take it up,
answers.
but yes.
Okay, I think we're now at Christina.
David, you and I talked a little bit about this. I still wonder if we need to look, and maybe you can give some insight to that, differently with pediatric patients. I think the study that was at AAP that was presented was 1 in 20 adolescents, and they had, I think, a 90,000 size sample. Their N was large. That 1 in 20 adolescents post-surgery receive narcotics 3 to 6 months after their surgery. So it may not be the volume they're being prescribed, it may be the length of time. And I wonder if we've looked at number one, or if there's a way you can look at it. What are those factors that preclude them from coming back to see the surgeon or getting into the primary care doc? So there's that communication. And 2, are there any established systems that do a good job at that communication between the surgeon when that child goes home to the primary care provider to let them know if they come to please call us? So I don't think it may be for adolescents the number of pills, and we know they're a high-risk population with prescription drugs. I think it's the length of time. And I know in rural Georgia, asking families who don't have the financial means to come back in, 2 or 3 hours to the hospital is quite a burden on the families. So they'll prescribe again medication. So I wonder if there's some way we can wrap our head around how that system may truly impact drug addiction.
So a great reminder is that we had already brought up the issue of older adults and what's happening there, and it's not the same as what's happening with working age adults. And you're reminding us we can't forget the kids. There are real issues there, and they may be a smaller part of the problem today. But that doesn't mean it's important, and it could lead to the future. And by the way, we also have a project looking at neonatal abstinence syndrome, and we're part of the data infrastructure for the country. And there is a very nice coordinated effort to address that. But all of these groups need their own focus. Thank you for.
Kathy.
Stepping back just a bit and viewing this more as a lens, I think this provides a really good opportunity to consider how you were able to respond to the opioid crisis and what you wish you had, to do somewhat of a self-study and looking back to say what kinds of data needs do we wish we had, how do we use this as an opportunity to figure out to be prepared more for the next crisis that's inevitably going to occur, and to think through this, because there were warning signs that this was a problem that was emerging. What is it that you wish you had and could tie in with your data group and be more responsive?
So that actually raises a general question of how you use data to predict problems as opposed to respond to problems, and whether your data is current enough to allow that. When I was at CDC, we managed to miss a nationwide epidemic of sepsis due to contaminated IV fluid for months because we didn't have data set up in the right way to look at it. This is punch card days, but still we had the data, but we weren't really using it.
Yeah, It's a tremendous set of questions, and it could lead to lots of thinking. One of the parts of that, though, that I think resonates enormously is solutions that solve only this problem are not nearly as valuable as ones that get to underlying issues that could either set us up better for the next crisis or avoid the next crisis because we learned from this one. So that we're always trying to think about that. I think we need to write this up, but AHRQ was one of the first national agencies using our data, as old as it, quote, might have been, that showed that something was happening that was different. And we were actually, Pam is probably on the phone, testified in Congress showing our data way before this became the household media discussion that it is. So we were an early warning sign. We probably could have been even, but what you're reminding us, we should have been even earlier. So but.
Or had a way to get the message out.
Yeah, how could we have
And
been
a more
heard?
powerful, if you
Yes.
had the data and you were out front, everybody should have known about
that.
it. What could you do?
Yes. We have to ask ourselves that question. Thank you.
Quickly, why are those 3 states not participating in providing data? Is there a reason? I noticed there's 3 states on that map.
Yeah.
Are they
So, I mean, we know this.
states in the south?
The ones on that map and the AHRQ program overall and HCAP are slightly different questions, but Ginny, do you want to answer, give it a,
It's very simple. The data belong to the states. It's up to them whether they participate. One of those states has legislation saying they're not allowed to. And the others have various issues that make it inappropriate for them to participate on the national level.
the good news is that it's now, I believe it's 98.9% of all non-military hospital discharges in the US are collected in HCAP. So yeah, we're missing about 1%, but that's pretty, and for those just thinking, we used to do the sample, right? It was the national inpatient sample because computers can now handle that. So we're no longer doing a lot of our research on the sample. We're doing it on 99% of discharges. So.
Interesting. So we only have a few minutes left. I know that there are a couple of folks. I think that the rule of order is that the members of the NAC get first call, right, as opposed to the representatives from other agencies. So, sorry. So I think, Beth, you had your hand, then Bob.
I just wanted to comment on Tina's comment about the 5 for the initial prescription. I think as we look at the state's data, everyone has implemented their plans as of this year. So when are we going to go back and look at the state data again to see who's turned green and see what they are doing in those states that's made a difference? Because I think that will be your answer to number 1. And that will help with limited funding because you've already have your test sites there. I know in Michigan, we're using the MAPS program. They use a checklist that addresses those pain management issues prior to prescribing. They have a whole, lack of better terms, prescriptive role that the physicians has to follow to prescribe opioids. Also, the Narcan issue is an issue in the state of Michigan, where we have a order for Narcan across the state with participating pharmacies where anyone that has an opioid overdose can go and get the Narcan immediately and hopefully have a successful outcome.
So a great challenge to us to keep updating the data. That will show us patterns that we'll want to look at who's turning it around and what are those factors. I hear you. You can go on the AHRQ website, and for some states now, HCAP has it quarterly, their hospitalizations. And so we can watch that trend, not quite in real time yet, but within the year, we've got their data coming out. And it's fascinating to see there really has been a change in hospitalizations nationally, as we're looking at the newest data, but it's not, it's a flattening more than a going down. And finding those first states who go down and then looking back, what did they do? And sharing that information, that's a great suggestion. Pam, I hope you heard me.
So this will be quick, but in the light of never wanting to let a good crisis go unused for the purpose of management. You mentioned this is an opportunity to highlight the contributions of AHRQ. So when you said that we were way out of front in being able to identify this, you would want to market that appropriately and be able to let people know that whatever the next one is, maybe you'll be out ahead of that also, which is important for people to realize the value that AHRQ can make. And then in these partnerships, there's reasons that they're partnering with you because it's perceived you're bringing something that those other partners don't have. And while people are thinking about this particular crisis, I would encourage you to be sure those were well articulated, thought through. You had the elevator speeches for each of those different pieces and, in terms of enhancing what you're contributing.
That's a great challenge. Thank you.
So along those lines, since Chesley put down his card, I'm going to just ask a question. So I've always thought that the agency that dealt with national epidemics was CDC. And so I'll just ask a pointed question: is who will be the?
We are all in on this together. This is the most coordinated, organized response. I mean, you don't get to see it the way some of us do. CDC is part of this, CMS is part of this, FDA is part of this, AHRQ is part of this, NIH got $1 billion a year for new research for this. HRSA is doing things both in rural and underserved communities. Everybody is, ACF, everybody is trying to think about everything they can bring, not throwing it, but thinking about what their roles are, where are the gaps.
Yeah, so this is the opportunity for the elevator speech I was hoping you could give and probably are giving, which is not the short elevator speech on what AHRQ's data shows or whatever, but how federal coordination and perhaps with others as well. Google is actually pretty good at finding flu epidemics, probably as good as the CDC in some respects. So articulating who's doing what to be prepared for the next whatever would be really important. When we look at pandemic preparedness, as far as I can tell, the public still doesn't understand, and most people in academia have no idea how it all works together. So here's the opportunity to actually, you've done this work. I would point that out. Public, be assured your government works for you, and lay it out.
Thank you. Don.
Andy.
So I think in addition to the data piece, which is critical, I think one of the things that AHRQ could also help with has to do with what is tackling a complex problem like this, look at an organizational level. So Bill made the point of synthesizing best practices. There's a lot out there. What we tend to do at the health system level is get very granular about a solution, in this case, prescribing. So, however, at a sort of an executive level, what people are thinking about is, we have a complex problem. How do we solve it? So what do the teams look like? What are the interventions that we do first? The NQF playbook touches on that a little bit. What would a scorecard look like? Those types of things at an organizational level that I think really get to the how and the implementation and deployment piece, which again is what I think at a higher level could be AHRQ's sweet spot in this.
Okay, so I have just the last question, and which I'm pretty sure you have an answer to. So you've gotten some feedback from the folks here as to potential gaps or things that AHRQ can uniquely do. As you've done that really fantastic networking with all the other agencies and entities, where do you see the gaps that AHRQ has not yet filled but should fill or can fill? Are there any gaps? Maybe there aren't.
No. So Don, before I say it, Sherry and Chesley, I'm giving you my cards before we leave. I know you know how to find me, but I desperately want to hear your feedback as well. My elevator speech on that is, I think AHRQ, again, has 3 capabilities, and we need to move on all 3 of these. In health services research, in practice improvement, and in data. In health services research, you've given us more, but this idea of the natural experiments in policy that are happening and rapidly learning what's working and what's not, and I would challenge us that some things we didn't expect are going to happen, so what are the unintended consequences? We need to know that. I probably won't go in, Lucy, to like, what does CBD do? Because that I think is an NIH question. They're going to be putting money into new pain. Well, right. There may be some questions then about policies and how do we make this accessible and stigma and patient-centered. But I'm personally worried that we don't understand what's happening with older adults and that this is complex and AHRQ could shine a spotlight on this and get system thinkers understanding this so we can help health systems do better in that area. So those are, there are probably other health systems questions. On practice improvement, this idea, I think AHRQ primary care still needs more help, and it starts in pain management and safe opioid prescribing and making it easy for them to do the right thing. But I forget who said it. I think it was Andy. Systems need this help too. So we need to go back and think about what the playbook is missing and how do we help systems. Those are our sweet spots. Practical tools that are evidence-based for health systems to make it easier for more of them to do the right thing, and for primary care who's often doesn't have a home for their information. We can move both of those. And in data, the department is moving in all sorts of ways. So we're going to continue to watch where are the holes and try to fill that, partnering with our colleagues at CDC and elsewhere, while maximizing what HCUP and MEPS can tell the world about these problems.
What about the state data?
Gopal, as you've just witnessed, always reminds me that our question of that AHRQ's data sets are national and can be useful for national policymakers is true, but there's probably enormous untapped potential in continuing to drive our data into the hands of state and local folks, both learning what they need and making sure that they get it. So that's another area that I think AHRQ in the future can move into. And we're trying already, but we can do more.
Does your data track the evolution of the epidemic as it goes from its where it was initially highest impact in white folks, certain income bracket, towards Black people living in inner cities? Do you have data?
I would challenge you that I don't actually personally think that's the way it goes, but
Well, maybe
yes.
not. I mean, you tell me how it goes.
Well, and so HCUP data does let us see, because we have so much of it. Now, the issues of who's using the ER and who's using the hospital or being hospitalized turn out to be different. It is not everywhere where ER is high, hospitals are high. So we are interested in trying to understand what the difference is. And we know, and we have the data and the research to show it, that who's dying of opioid overuse is not always the same in where hospitals are being used for opioids. And the natural thing is, won't all of these track the same way? They don't. There are communities where people are dying, but they're not using the ER. And there are others where the ERs are doing a lot and people aren't dying. So trying to understand that. And so the team right now is diving into that to try to understand what we can learn and what we can tell people about that. They're planning to bring in the social determinants of health in a much more robust way to try to see how those are factors that local communities can use. And I think most excitingly, they're trying to think about how do we model forward? How does the evolution of this epidemic allow us to use our data to try to make predictions, hotspot, in advance, let communities know that they're starting to show the warning signs that that something may be happening to them. That would be very exciting. It's really hard in this field, though, for those who are really in it, because how this epidemic has unfolded, the pills are at the heart of it, but heroin changed it. The availability of black tar heroin changed the epidemic in the US, which has now been changed by fentanyl and its analogs. We are in at least the third wave of this. And if we had tried to do our predictions without fentanyl, we would have gotten it wrong. So modeling is great, and we're going to do it, and we have to be humble as we do it. That's our plan.
That's great. Thank you. So we have at time on this topic. Thank you very much. That was extremely helpful, and I think you got some good ideas to go forward. Impressive amount of work that's been done, and glad to hear about the interagency collaboration. So we're now ready for Francis, who's moving to the microphone and is going to talk about where the C-suite comes in, and specifically HSR and the C-suite. I have a certain allergy towards the term C-suite because I always imagine who these people are sitting in their little C-suite. And but it's I think you mean leadership or the boards of or. How many people here are in the C-suite? See that? You have, the C-suite is amply represented, and as best I can tell, they look just like everyone else. So,
Thank you for that introduction, Don. I can tease Don a little bit. We go back a little ways over the years. So we've touched on this topic a bit already, and especially in the data presentation where we were talking about the intersection of data and making data from a health services research perspective relevant to the C-suite. And we heard some comments earlier about, in particular, the pace at which health services research is done and the lack of congruence with the reality of how the answers are needed in real time. And so what I'd like to do today is to queue up some questions that talk about a component of the future of health services research, much like we heard from David from the perspective of opioid and opioid research. Here it is actually thinking about a specific customer for our health services research. In this case, it is health systems and those who lead systems, as Don said. And this is just a sort of an abbreviation. The term is C-suite. So what I'd like to do to start us off is to share two examples of work that AHRQ is currently doing and then pose some questions. So this is, and quickly I'm just going to describe the Comparative Health Systems Performance Initiative. It's a project that was funded, began a few years ago to study how healthcare systems use evidence-based practices to improve outcomes and reduce costs in delivery of care, and in the process build robust research databases. And that's the key, I think, in terms of future work that will identify, classify, track, and compare health systems. And so by way of recent accomplishments, we have published a couple of years ago now, almost 2 years ago, a compendium of U.S. health systems. And we have 3 centers that have been funded to do this work, and the work is ongoing. But here, again, it's a health system-focused project, which is in some ways cataloging health systems and developing a database for future research. A project that is near and dear to my heart because my office does facilitate and lead the health services research training and career development programs, is a project that we started a few years ago by first recognizing that in order to have a companion focus in health services research training, in which the goal was not necessarily to publish and ascend the academic ladder in the academic health services research centers, though that is certainly fine and that is a component, an outcome measure for some of our training programs, but rather to embed researchers in systems to produce research that's valuable and useful to system leaders in real time. We realized that we had to first think about what are the competencies of researchers who do that work. And so we funded a project to build some competencies for researchers in health systems. Those competencies have been published and they're available on our website. And then we published a funding announcement in collaboration with the Patient-Centered Outcomes Research Institute, in which we're going to co-fund a bunch of projects actually, which will fund institutions to build partnerships with systems. That's a requirement. To use system data in the context of that partnership, that's a requirement. PCORNet is a perfect example of that, where some of the soon-to-be grantees will be using those data, and to commit to embedding these researchers in systems to learn how to ask questions that are meaningful to system leaders, and to continue to evolve as system researchers and system leaders. The output, hopefully, is folks that are committed to working in systems and helping to answer quality improvement and operations questions that system leaders have. It's a 5-year program. We're committing $40 million for Corey and AHRQ over that period of time. And so these are just 2 examples of projects that are ongoing. But the question for us is, how do we tip, if you will, this collaboration between AHRQ as a funder of health services research and quality improvement work, the need that systems have for real-time data. And so I've posed a few questions. Now, interestingly, these are questions that we've sort of touched on a little bit this morning. I'm channeling Lucy in that 3rd bullet. How do system leaders instill a culture of learning and improvement among staff and teams? So I was sitting in, Lucy, your Academy Health session, and so I heard you talk a little bit about that, and so I said I'm stealing that, but I will steal with attribution. Because we think that's really important, and we've heard that in conversations. That's important. We touched a little bit on this morning. I think on this issue of, so now we have a research paradigm that is a 3 to 5 year model of funding a grant that will produce really valuable research that probably answers a question that was needed maybe 3 years ago. I think in a session we convened at Academy Health, we asked the question, so how can health services research be valuable to systems, but how can systems embrace that opportunity, and how does health services research need to change in order to produce real-time value? What are some of the methodological changes, for example, in the kinds of research and questions that need to be asked? But I'd actually, so we can talk about these, but I'd actually like to focus on these questions because they kind of get at actually the tension that is in place as we think about traditional health services research training, where the incentives are to produce researchers who live in academic health centers for the most part, and who produce research that is publishable and folks who will become academicians. So how can we encourage early dissemination and implementation of findings, which is really counter to the publish or perish paradigm? In other words, oftentimes those two issues are at odds. Is there, in the competitive environment that exists, is there an opportunity for health services researchers to facilitate cross-system learning? And perhaps most importantly, and coming back to a comment I made earlier this morning, what are the metrics of success and how can we measure impact? For example, is there a way that this research and systems can demonstrate value? And exactly what would that be? Return on investment, or perhaps a focus on quality improvement in systems. And one of the things I've been thinking about is this, what I call the p-value issue, which is, so what does it really mean to researchers, journal publishers, and operations leaders, this issue of when do we know enough to act? I mean, the p-value is just sort of an acronym to say, obviously we know what's publishable as it relates to p-values, but when do we have enough information from a system leader's perspective, and when can that information become actionable? So, keeping with the theme of today, I'm just posing these few questions with these few slides, and really want to use these, Don, as a prompt for some conversation and dialogue around the theme of health services research and how it can be relevant for really important partners as it relates to moving the needle in healthcare improvement and quality improvement, and that is health system leaders.
Well, thank you. And first, I have to take a moment just to compliment the presenters today. I've seen many occasions people promise, swear, and do all kinds of things that they're not going to show a lot of slides and they're going to leave time for discussion. And this is the first time in my life I've actually seen this happen. I mean, this is great. I think a round of applause to the presenters.
Well, truth in advertising, Jamie's a part of the solution here, pushing us to keep our presentations precise, but also to push the discussion along.
Yeah, she does that to me too with far less success.
I may add, the secret is that at the last meeting, the incoming chair said, Gopal, there's too many slides, we should have more discussion. So here you are.
Wow, this is easy. Well, anyway, we have some time now for discussion. And are these new tent things? Okay, we'll start with Will and then Bob and wait for others to write. I'm sorry about the making you guys put down your things. So, but this might be a time where we'd appreciate your.
I'm going to try to respond to two of the questions. One, the p-value one, and another around sort of some of the methodologic questions you brought up. I think the p-value one is a really salient topic because the business community makes decisions very differently than a journal, of course, and any business that waits to be 95% sure that something is true before acting will not long be a business. And finding, so there's a temporal disconnect between a research community and a business community. The business community needs the answers faster to make decisions. The research community, of course, wants to be right. one little example that I think it really was sort of illustrative was I did a project once with Aetna, where we randomized people that had a heart attack to usual care to get their drugs for free. And the patients who got their drugs for free were meaningfully more adherent to their meds. They had 11% fewer subsequent vascular events. On average, Aetna saved about $1,700 per patient, but it wasn't statistically significant. The New England Journal published it as a sort of not as a clinically beneficial, but financially null finding. And on the same day that that article was published, Aetna scaled the program with clear financial expectations of benefit, budgeted expectations for benefit. And we've since seen a lot more expansion of this value-based insurance design, in particular around these very, sick patients. That's a case where I think the research community, has held back or was slow to sort of adapt to what was clearly a benefit for a business and for patients. And I think that this is a really important. I think it's really important to kind of shine a light on this, because as you're funding research and as you're interpreting research, that too much attention certainly falls to that p-value. The other thing, methodologically, one thing that I think is really challenging, and I think it'll be particularly challenging for sort of the academic community, is when we're testing things in the real world. We're testing, let's say, a new payment model, or we're testing a new clinical intervention. It's very rare that that intervention or that payment model is either a good or a bad idea. It's generally a good idea, and its success or failure generally relies on some aspect of how it's being implemented, how it's being targeted, how patients are being engaged, how providers are being engaged. And so the only way for these interventions to really work in the real world is to get real-time information, real-time feedback, learn what's working and what's not working, and make refinements, mid-course corrections to try to really understand what does or doesn't work. It was a big issue as we kind of rolled out payment models as part of the Innovation Center, because most things didn't work right off the bat, and it wasn't necessarily because of, aligning financial incentives is a bad idea, but because it's hard to make the necessary transformations in clinical practice. It forces us, and I think it would be of great value if AHRQ had a sort of a position on this, to make some decisions methodologically about how much rigor you're willing to give up to be able to make corrections. You do have to give up some rigor to say this is not going to be a perfectly controlled experiment. This is an experiment that, by definition, there's going to be some sort of, you're going to mess with the scientific method in order to improve the likelihood of success. In the absence of that kind of philosophy, I don't think we'll ever be successful in any kind of clinical or payment intervention in this country. We will just be sort of stuck with whatever we've got. But there is always pushback. There's pushback from an academic community. There's always pushback. And I think to the extent that you could help clarify what is reasonable to interpret, what are fair methods to use in this sort of space of quality improvement research where you're making real mid-course corrections, real-time adjustments, that would be really, really helpful for those of us who are doing it day in, day out.
That's great. Just clarifying around this p-value in academics and 0.07s. So are you advocating for a kind of a Bayesian approach to this, or do you want to get an argument with Ioannidis, who said we ought to be using a p of 0.0001 before we spread stuff that turns out not to be true?
No, I think it's more of sort of almost an IHI philosophy, that you have to really think about the context, right? It's not as though there's not a number that's right. There's not a cutoff that it will be appropriate for all studies. You always sort of have to think about the risk, the benefit, and when you're talking about not publishing an article, but you're talking about making a decision, it's about risks and benefit for a real population or for a business or So I don't think there's a sort of a simple answer to that, but I think any effort to come up with a simple answer is fraught in sort of conceptually.
Yeah, there's no simple answer. I'd be happy if it's part of this work, though, the specifications for how you make these judgments be spelled out. So Patrick Conway went around saying about the diabetes prevention program, why that was scaled nationwide based on one randomized controlled trial. And, he made a pretty compelling case for that. And it was clear to me what CMS had in mind when they scaled that. You probably know more about this than I do. But the considerations that went into that are actually an object lesson that I don't think have ever been fully explored. So just to make my own editorial on what you said, this is fine as long as we're really clear why we're doing it and how to make those judgments.
So just a follow-up comment on the bills on this, one of the things that we're funding as part of the Learning Collaborative Training Program is, the training program grants is a learning collaborative amongst the funded grantees in which we're going to pose these kinds of questions, because these are tough questions. Obviously harm and balancing harm is important as well as benefits. But in order to get at this, and I think in order to move the field forward, actually, in terms of how we actually can be relevant in health service research and systems, we have to actually confront these questions. And so that's what the Learning Collaborative is, part of what the Learning Collaborative is intended to do.
Just bookmark, I'd like to come back to the Learning Collaborative and hope maybe somebody will ask a question about what this is going to look like. But if we don't get back to me, so Bob, you're up next.
So as a epidemiologist, clinician, and decision analyst, I've always felt comfortable moving in and out of the frequentist and Bayesian world. And there's no question that in the C-suite, you're working in a Bayesian world where you're trying to advance things with best knowledge. But I see this as and not or. And let me just explain a few things. So we work very closely with our operations, have a very formal learning healthcare system program that includes all our CEO and CNO and COO, and as well as our academics to do, on the one hand, pragmatic clinical trials, which we've published and quickly and changed care. Not everything, obviously, is amenable to a pragmatic clinical trial. As a decision analyst, I get that totally. But so you don't have to give up rigor, and it doesn't have to cost a lot to do some very important, meaningful projects that are relevant to leadership. You have to organize yourself and try to identify them. So you can have that arm. That needs to be promulgated more across the country, and more of those need to be done, because I do believe the rigor provides you the evidence that others will want before you'll be able to spread and before they'll believe, as Don said, you have something worth appropriate to spread. Is there a role for health services researchers? Sure, there is. And we do that all the time in terms of trying to learn from each other. Metrics of success, I think, are related to trying to understand what your user, your client needs. And if that is the chief medical officer or the chief of a clinical service, just have to work closely together. One of the merits of these training programs that you're investing in, thank you very much, because we're the happy recipients of some of those. But for 20 years, we've trained people through the VA Quality Scholars Program. We have 25 alums on faculty at Vanderbilt in both leadership roles and research roles, and they all work closely together, and they kind of understand each other's paradigms and each other's perspectives and what they're trying to accomplish. So I don't feel like you have to eliminate rigor, but you have to understand the breadth of different study designs. So at the same time, we've been developing this learning healthcare system with pragmatic trials, NIH, CTSA supported. We have a Center for Clinical Quality and Implementation Research, which works with all of the operations leaders that want to do QI, but do it in a way that has rigor and still can be evaluated. And that means the right measures and the right metrics that have validity and reliability. And if you're getting the right comparator group, if it's depth wedged or whatever it is, there's a variety of things that you can do if you pull that infrastructure together. And if the system feels like they want to go ahead, like they did at our place with a different kind of soap that we weren't sure worked, but they thought some literature showed it did. So as they did it, we studied it and then eventually showed them they were wasting their money and they changed their mind. So sometimes you use the natural experiments, but with rigor. Sometimes you do it prospectively through randomized, controlled, pragmatic clinical trials. Sometimes you use other designs, but you need the infrastructure and you have to build the culture. So we had to put our arms around the operations people and bring them together to understand why this was important, why we could gather evidence, show them some winning examples of how it impacted them. And so to me, I think that can happen. I think we're an example of that. We're not the only example of that. And I think you just acknowledge, yes, some people are going to use Bayesian thinking, and what's the next incremental best information you have at the time when you have to make a decision. That's just the way decision-making works.
Well, that's really helpful. It sounds like you're, in a way, advocating for a core curriculum about design and evaluation for this K-12 award as part of the collaborative, because I don't think you can assume that knowing how to do this kind of research you've been discussing is widely implemented around health systems in the U.S. I don't know, maybe the grants have really compelling information on this, but I doubt it.
So that's a really good point, Don. And actually, part of, again, the Learning Collaborative is actually, each of these grants will start with a core curriculum, but there's much room to learn exactly what a core curriculum looks like when applied in a learning health system. And so that we expect that to evolve. We expect part of this project to disseminate and then implement those curricula in other settings, beyond just this one grant program.
I mean, just to be frank, having seen the RFP and having responded to it as a member of a team, it was really easy to regurgitate the competencies from a report. And there seemed, as I looked at stuff, to be a real gap between understanding what actually one did to implement and evaluate, as opposed to we have a course, we're going to cover all these curriculum. In fact, a lot of people, I think, just plugged in one that already exists that is grossly inadequate for the purpose that we're talking about. Sorry. Remarks from the chair yet again. I think we are up to Monica now.
Just a brief comment. This is Monica Peak. Just a brief comment about early dissemination and implementation. I think a lot of us do disseminate our work at national scientific meetings in form of abstracts, but it would help tremendously if more journals were open to getting works in progress. And so it's not that it's inherently counter to publishing full manuscripts, it's just that there's a hesitance you can do both. But people would like to see a finished product. And so to the degree that AHRQ is able to support that, either philosophically or sponsoring special issue journals in collaboration with other agencies that highlight, progress in the field or, early works or whatever, that get to this point of early dissemination and implementation of findings that are around a core content area that you're interested in, I think would help investigators be able to have a venue for putting some of their work out in advance.
Thank you. I'm just doing a time check. Jose.
So just a couple of comments. The first is that it seems, people are good at doing what they like to do and what they know how to do. And one of the things that I think has been missing and is missing is the capacity, the people who are actually knowledgeable about and skilled at doing the kind of research that we've been talking about all morning, sort of the rapid response, flexible, et cetera. And so in a way, I think this K-12 program has a possibility of filling a hole that exists now, and that probably offers the best hope for training people who will do this research well and that will actually be useful to health systems and providers and so forth. And it probably will, hopefully anyway, if it's done well, it could lead to a cohort of people who are able to make the trade-offs between, for example, rigor. This isn't to say, Bob said this research can be rigorous and should be rigorous, and I understand that. But the trade-off between when do you sort of stop seeking more rigor as opposed to just getting a result that you can use. The trade-off between the degree of certainty that you need as captured by things, mundane things like the p-value, versus, I think we know enough with this point estimate to work, to move forward and do something. I mean, these trade-offs are really implicit in any effort to have research that is used in these very practical, applied ways. All of these trade-offs are required. But I don't think that the standard researcher really knows how to make those trade-offs because they're trained in a particular way. And to use language that Bob used, and I won't repeat myself, I'll just say it, I think that this isn't either or, it's actually both and. So both types of research are necessary and both types of research are important. But this second type of research has not had experts in it. And if this were to be a successful effort, I hope it's one that will continue and that will grow, because these folks will surely have a place in institutions that are and systems that are seeking to provide care. The final thing I'll say is that I hope this initiative itself is actually carefully evaluated, because we don't know what's going to turn out from it. So one of the key things that I believe you need to do is to, as you train these folks, really evaluate what they're doing and evaluate whether they're making a difference.
That'll pose an interesting challenge right away on embedded research, which is the degree to which the evaluator is totally firewalled and comes in like Westat or somebody afterwards and says, okay, you failed or you didn't, as opposed to working with institutions who are funded so they understand what the design is and what the evaluation is going to be and can harmonize so the evaluation actually makes sense. So that's something, part of the parcel of the job.
Just a quick word on what our plan is in evaluation. So we have, again, using our learning collaborative and expertise that was required to be part of the grants, we're actually going to, again, put together a plan that evolves as these programs evolve to do the evaluation from inside to both learn. That's not the only way to do evaluation, but that's within our resource constraints to be able to do it that way. But we do hope to be able to identify metrics of success. I think, Jose, you're exactly right. We're not clear, actually, what those metrics are and how those metrics may vary based on our traditional training programs, which, by the way, we're not abandoning. And we've learned a lot about what success looks like in those. And so we're going to marry that knowledge with learning what success looks like and what the metrics are in these kinds of programs where they're focused specifically on success from the perspective of the systems.
Lucy.
So I'm going to talk about the first three, and thank you, Will, for doing four, because I agree with everything you said. The first one is something I feel pretty strongly about. Chuck Friedman and I have been sort of on a speaking circuit dealing with this first issue. And the extent to which, we believe in these learning health systems that are actually with embedded researchers generating evidence that are not necessarily incentivized to publish. There's very timely evidence that exists there. And so the extent to which we can find some kind of communication mechanism, and Chuck really talks about a standardized template for computable knowledge. So instead of embedding things in figures and text and things like that, are there ways in which we can have data representations where we can synthesize what we know from the evidence reports together with this emerging evidence that's coming out of the delivery systems? That's one way to make it more relevant, and we haven't really thought that through. The second one, in competitive environments, I know Andy and I have been involved in the High Value Healthcare Collaborative, which is a collaborative of delivery systems around the United States that really came together because we believed that there are some issues that required larger scale learning. Healthcare System Research Network does the same thing. So I think that there are ways in which delivery systems can come together for the shared learning experience. And then the third one on the metrics, I've been working for the last 3 years trying to develop a metric around impact for value. And it's really important, and I'm speaking as an MBA person here too, to get away from ROI. because not everything is quantifiable. And in some cases, the value of quality improvement supersedes the interest in the cost savings. And so unless you're looking at it in a more holistic way, it's meaningless. And I'm hoping that that's one of the things that comes out of the collaborative learning.
Great. I do agree those two collaborators you mentioned are good models. I'll add that Commonwealth Fund has funded a innovation collaborative among 13, actually 14 initially, large healthcare systems designed to see whether or not you could test and then spread within those systems innovations from other developed countries. And what I think we've learned from that is having a really pretty firm structure and facilitation around it with a good advanced evaluation plan. That's being evaluated from within, actually, just as you said. But it turns out it's really tricky to keep people on track and to have the evaluators of each organization really working together in a meaningful way. So definitely, as part of this, you ought to be finding out what the learnings are from those, at least those three networks. There's a sort of cut and paste way that learning systems are put into grants and contracts, and it's sort of somebody goes in IHI and pulls out something called the Breakthrough Series Collaborative thing, and they plunk it into an RFP, and then people try and do it, and that's not at all what this is, obviously. This is an innovation learning system. So that was a really helpful comment, and I see you're shaking your head, so I think Cheryl, you agree with that. So I think now I've passed over Jerry inadvertently. Go ahead.
Yeah, just a quick comment. I think the focus on culture and learning is great. When I talk to C-suite leaders, what their concerns are is their bench strength, that they have perhaps, and we see here some great leaders at the top, but as you start drilling down into the organization, the amount of knowledge and experience is quite weak. So I think having that curriculum, but maybe having a curriculum that can be transferred to those lower levels, even within large systems as they drill down to regional medical directors or regional nursing directors, there's a huge gap in their ability to understand these concepts and then apply them. So having, if you've thought of that as part of your charge, I think would be valuable to the C-suite.
I'm not going to shut you down. You're next.
So I have a question that I will ask, and hopefully my asking it will be helpful to my Agency for Healthcare Research colleagues. At CMS, we are very interested in, of course, improvement, in improving outcomes. We're also very mindful of administrative burden, as you may have heard. So curious to know, when we think about that word dissemination, especially early dissemination and encouraging it, thinking about what are the impediments that might be, operational aspects of burden, like what does it take to implement? And to what extent, if that can be thought of ahead of time, maybe it's not for AHRQ to do, but maybe in partnership with others like us, does that factor into the calculus of the C-suite? Like, here we have something that we want to implement early, and yet the evidence is emerging. What will it take to implement? What are the resources to implement? What are the, just hearing you speak of, rounding with involving patients, like what does it take to do that? So just curious about what people's thoughts were about that aspect of barriers to dissemination, and defer, to Gopal and Francis, whether or not that's helpful to hear from folks on. But anyway.
I lost my 10 card, so I'll go after Karen.
Thank you. Karen Amstutz. Just one comment in follow-up to Sherry is that I think some standardized ways to think about estimating impact to a system would be really helpful. So again, tools that can be applied by systems that may not have the same depth of sort of scientific expertise. I also wanted to posit that maybe there's a need for AHRQ to think about research, to being a steward to research partnerships between academia and health systems. It seems like we have talent in one place that's looking for a study, a situation in another place. And when you're on the business side, having access to sample agreements for data use and data collaboration, having that sort of groundwork already laid out that gives you, again, a little bit of cover and protection from someone who's actually done it before would be really valuable.
Great. So I think Sherry asked a very important question. I will say absolutely that factors into decisions about what we pursue. And I think a challenge that a new challenge with the dawn of electronic health records is you cannot implement anything effectively without fixing the workflow in your EHR. And if you're in most organizations, you have a great idea, you have your metrics, you have your people lined up, and then they say, wait in line for 12 months while we fix the EHR. So that's a huge problem in terms of actually rolling this out. More broadly, I think that in terms of integrating the C-suite thinking with health services research, we want to, I think a sort of a barrier that we have to surmount is thinking of health services research as an extant activity. It can't be something that someone else does or someone else funds. It has to become a core part of system operations. And I think one of the outcomes of these training programs is you don't necessarily define success just by publications, grants, academic promotion, but it's by the number of people that you actually have embedded in operational positions and systems stemming from these training programs. That would be an important outcome. Terminology can be important, calling something research versus delivery science, and how that's perceived. I think that's sort of another aspect of it. But ultimately, you want to see this as day-to-day, that this is something that health systems need to be doing. In terms of what systems need for those implementation barriers, I think the potential impact of locally generated evidence is huge. You can have the most beautifully designed clinical trial, but if it's from another organization, it can be very hard to apply. So I think simple studies that could be replicated quickly at a system to sort of reinforce this isn't just happening in California or New England. This is happening. These numbers make sense and they match what we found in our particular patient population. That is hugely impactful in terms of changing provider behavior. And then the other thing is evidence that allows sort of contextual tailoring. So rather than having a fixed toolkit and saying implement this, come up with a set of 10 best practices and say that you could potentially dial up and down according to the system environment, the system context, what might work in a 3 to 4 physician practice versus a large health system with 50 hospitals. But then also, as we get into the precision medicine era, what factors can you tailor to the individual patient level? Again, the critique is always that we're given a set of a set of tools and interventions that's too broad or can't be applied to the matter at hand. And I think all of those, that's sort of the next horizon, as I see it, for what the systems really need.
David, you had your card up.
This is David Atkins. Just wanted to echo Bob's point because about it being an and. I think there are 3 things AHRQ can do. One is to build on the kind of examples that Bob's side has done. The VA is also working on this about how to continue to do rigorous research, but using natural experiments or more rapid designs so that it's not a choice between a 4-year project, but still maintaining the rigor. The other, though, is to figure out how to make our QI methods more valuable, more reliable and rigorous. I mean, I remember when I was still at AHRQ 15 years ago, Ed Wagner sort of saying the one thing you could do is bring the QI world and the health services research closer together. And, for all the researchers who are taking too long, there's also plenty of lousy QI that's being implemented. And, we have to figure out where we can help, if not telling people not to try something, but at least helping them go back and test whether their assumptions actually bore out. And then the third is this issue of creating the incentives for people to do this, kind of live in both worlds, where academic promotion isn't tied to publication. And I think the things that AHRQ could do to help that for people who are living in worlds where publication isn't the world is to think about ways to measure impact, create honors or awards to reward people like that, and to create funding mechanisms where, because the other realm for promotion is funding. So if you can get funding, but to do stuff where the end goal isn't necessarily publication, but the end goal is system improvement or training or something, then those are two things that will attract people to live in a world where they no longer have to live by the standards of the journals.
I just wanted to respond, kind of echoing where Andrew was, but just a few more comments back to Sherry. Number one, how projects get prioritized, I found in most medical groups and health systems. Number one, there usually has to be a champion. So I would say often it is personality driven. So figuring out who are those champions that you would need to touch and convince within those systems is going to be very important. The second part is IT. Most health systems, IT systems are way overloaded, and if you have to get in the queue to get the project approved. So anything that you can do to make it easier on the IT folks to say yes. So anything you can do on the measurement front, the evaluation front, that, if you will, kind of serves it up to them so that it's easier for them to implement as opposed to taking them hours and bodies.
I just had one last comment on the need to maybe merge QI and health services closer, and there is an opportunity to think about that through the accreditation lens and the standards that are set for our health systems, and getting those a little closer, and potentially also looking at it from a policy perspective, what's actually written in law and interpreted in regulation in different states that are then required by health systems to implement.
All right, that was very valuable dialogue. I have a few comments of my own that I saved up and probably synthesizing a lot of what you've heard already. This is really important experiment. It's novel. It's creating a infrastructure for something that I hope will grow and be a fabric of health service research in the future, and kind of a flagship for AHRQ. So that said, there are 4 threats I see for the what do they call K-12 what do I call them? Fellows. Okay. So here they are. First, most organizations don't really have a clue of how to use these people, honestly. I don't care what they wrote in their proposal. So they're going to tend to want to plug them into something that's already going on. That's not necessarily good learning. It's okay as a facet of their learning, but that'll be a temptation. We want to succeed. We got this going on. You go do that. So they don't get to design and create and do all that. Secondly, well, we don't want to plug you into something, so you got to learn from developing your project. Well, good luck with that. You got to build all your relationships. The time is limited. You got to do collecting your own data, find the data sources. So that's a threat on the other end. Then the third would be a lot of these are based on data, right? I mean, a big emphasis on large data sets, on PedsNet or whatever it happens to be. Okay, you go do this relatively small and relatively non-strategic secondary analysis data set, and we're all set. We'll have learned something. It'll be learning health system. We learn from the data. And finally, it'll be really hard to align the projects of the fellows with the strategic goals of the organization. Organizations tend to force any old project into the strategic goals or the driver diagram or whatever it is they use without really respecting the fact that its contribution to meeting the goal is really minute. So those are 4 things. And then there are 2 issues that are kind of learning system wide. One is the spreading of the innovation piece. I think you're really going to have a common curriculum about what are the attributes of a scalable model or an innovation. How do you actually go about thinking about what's scalable and how it's scaled? And I don't think that's probably a big feature of the proposals you got. I know in the Commonwealth Fund thing, the biggest, everybody wants to spread. They can't spread it to, Ward 6G, let alone to the entire health system, let alone to the country. So thinking about what that means to scale up, rapidly is a big issue for common curriculum. And I think there ought to be a common curriculum. I don't think you want to leave it. I know you want democracy and all, but there's probably a certain number of core curricular items that you don't want to leave to chance, and you want to make sure everybody participates and hears the same message. And then finally, some issues, if I can read my own writing, is about measurement. And we face this in the Commonwealth Fund grant, and I think it's true of most learning health systems. How do you take diverse projects and diverse fellows, all of whom are different, and roll it up into some metrics of whether or not they were successful in the program? And that's really hard. I mean, I think that's a totally tough challenge. And then how do you demonstrate the added value of the collaboration? I mean, it's fun. Everybody will say, they'll give it a Kirkpatrick level 1. We had a great time. It was, having Francis on those calls, my God, that was the greatest thing ever. But did they really get added value? Did they learn faster? Did they implement faster? Did they disseminate faster? So you think about that. And again, some of the folks who've been in these learning collaboratives may be able to help you. So those are just observations that kind of based on personal experience, and they may not be the right ones, but it occurred to me as folks were talking. Will, you had your hand up.
Can I just react to that a little bit? I think, well, there's always a risk that any of these sort of fellowships they won't be perfect. I did one of these GIM Health Services Research Fellowships. I spent about, 16 months meeting with people and looking for a data set with almost no sense of what the heck I was going to do. And not going to meaningful meetings within within a health system and learning how the business is working or learning how programs are being implemented, really just wandering around. I would say that you need good mentorship. You need a good sense of, you do need a curriculum, and I was lucky enough to participate in the technical expert panel for this AHRQ solicitation. So I know that there is a very clear set of expectations around a curriculum that these fellows will have, at a basic set of sort of skills that they're going to be expected to learn and classes they're going to be expected to take. But I think the risk here is so much lower than the risk of just having a useless general fellowship, where here you by definition are going to be part of something. Here you're going to be, even if it's not necessarily the most interesting program project, it's going to be yours, and you're going to be part of it. You're going to be following it from the beginning to the end, and you're going to care about the results, and you're going to be connected to the patients, and you're not just going to be trying to write a paper, but you're going to be really, really focused on your contribution. So I think, as I think about it, I think this is really going to be a much lower risk scenario than any other existing, sort of health services research fellowship.
And just for the public record, I wasn't being negative at all. I'm just saying these are things you can anticipate and mitigate so that it'll be the best possible experience. I don't know about that latter statement about the T32s. I think that if they're properly constructed and mentored, I think they're a great learning experience, but that's okay. Okay, Jose, you had your hand up.
One quick comment. I hope Will is right, but I also want to point out that there's a certain irony, because in much of this meeting and in many, many meetings I've been to, there has been sort of the lamentation about how conventional or traditional health services researchers won't do the type of research that can help health systems. And over the last 10 minutes, what I've heard is the barriers that health systems face to using research, even generated by people who are there internally and who've been trained perhaps to do that research. So there's a tremendous irony in that, in sort of the, lamenting that traditional academic researchers aren't helping, and then hearing that perhaps there's a certain immunity to being helped.
Yeah, well, it is interesting, just to give a plug for the AHRQ T32 program. Of all the 140 or so people that have been trained in pediatric health services research, a rather large number of them are now actually embedded in healthcare delivery systems doing health services research, often with a pragmatic twist. But that, I think, does depend on the kind of environment and culture and curriculum you said. If there's nothing in it about implementation and dissemination and those kinds of things, then, you know, they'll end up at RTI, which is good, by the way. Okay, so I think we've reached our time limit. There were no public comments apparently that were signed up for. So without having public comments, we are exactly on, yes?
I sit in a lot of these meetings, and I have to say kudos to you, Don. You did an excellent job and kept my attention the entire time, so thank you for your facilitation.
Well, I mean, thank you very much, Lucy. I actually think that dialogues like this are the reason why I keep so involved in coming to meetings. And the kudos really go to Gopal and Jamie, who created the expectation that this would be a vibrant meeting and challenged me to try and make it interesting and engage you all. And I think everybody in this room, except for poor Chesley, who I made put his card down, had a chance to speak. Do you want to, any last words, Chesley?
A minute.
Thank you for inviting me.
I've known Chesley a long time. He's one of the most collaborative and forward-thinking, innovative folks I know, and so I'm really glad you could attend. So thank you all. There are a lot of work. You guys, we gave you a ton of work, and we weren't kidding, because I think I'm still chair for a little while, and I will be asking accountability and all that kind of stuff. So we're going to have a really great meeting next time at which we get to sift through all the decisions you made and the work you've done. Thank you.
Thank you.
The next SNAC meeting is November 15th, if it's not on your calendar.